الحمد لله رب العالمين، والصلاة والسلام على أشرف المرسلين وعلى آله وصحبه أجمعين. Human Immunodeficiency Virus (HIV) and Acquired Immunodeficiency Syndrome (AIDS) by Professor Mahmoud Hani Sulaiman. Definition: Human due to disease agent found only in humans and only live in humans or on human cells. Immunodeficiency because HIV destroys immune system of body. Virus because a retrovirus equal it is able to convert RNA into DNA. It is called retro because able to convert RNA into DNA. AIDS is abbreviation of acquired immunodeficiency syndrome. Acquired because disease got uncaught. HIV cannot be caught from air like common cold. It spreads only by few specific routes. Immunodeficiency equal capacity of immune system to respond to infections is lost. HIV slowly destroys body's defense system. It kills important blood cells. CD4 T lymphocyte, without it, person cannot fight germs and cancers. So HIV infected person gets a number of diseases. Definition continued. Syndrome, collection of symptoms and signs. AIDS is last stage of HIV infection. AIDS is disease that presents with different kinds of symptoms and signs. Infections caused with immunodeficiency and opportunity obtained for many pathogens to infect that person are referred to as opportunistic infection. When people with HIV get OI, or when their CD4 T cell count becomes very low, less than 200 per millimeter square cubic, they have AIDS. OIs are life-threatening. Normal CD4 T cell count is 450 to 1020 cells per microliter of blood. Magnitude of the problem. Worldwide, HIV AIDS is one of most urgent threats to global public health. Global efforts to AIDS epidemic include increase access to effective treatment and preventive programs. Estimates of size and cause of HIV epidemic updated every year by WHO, UN AIDS in the coming table. In 2007, survey data showed number of people living with HIV estimated at 33 million. There were 2.5 million new infections and 2.1 million deaths during 2007. The findings are presented in coming slides. Total living with HIV about 33 millions. Newly infected 2.7, died of HIV 2, all this in millions. Over 6,800 new HIV infections occur per day worldwide, out of which more than 96% are in low and middle income countries. About 1,200 children less than 15 years and the rest about 5,600 adults aged more than 15 years. Sub-Saharan African bear brunt of global epidemic. 2/3 of all with HIV globally live in this region, a total of 22.5 million. Although other regions are less severely affected, 4 million in South and Southeast Asia, 1.6 million in Eastern Europe and Central Asia were living with HIV/AIDS. Almost 72% of all deaths due to AIDS in 2006 were in sub-Saharan Africa. More adult women are now getting infected with HIV. For every 10 adult males, there are 14 adult females living with HIV. Interaction of HIV/AIDS syndrome with other infectious disease is public health concern. This is estimated number of adults and children living with HIV infection as of December 2009. Total 33.3 million. HIV/AIDS epidemic profiling Egypt. In Egypt, HIV epidemic has never been a health threat. However, there is always fear that the epidemic may grow. Egypt's first AIDS case discovered in 1986. Since then, number of HIV reported cases are showing a steady increase and estimated to double nearly every 5 years. Figure becoming slide. Here, the number of HIV/AIDS epidemic in Egypt from 1992 till 2012. Now at 2008 it reached about 3,000. This is the number of HIV and AIDS patients, people living with HIV in Egypt from 1986 till 2011. It increased. It reached in 2011 about 3,000. At 2011, total of 4,781 HIV cumulative cases detected in Egypt, of which 3,746 were Egyptians. Most of them were Egyptians. In year 2011, 2,471 Egyptians are known to be living with HIV, among whom 388, about 16%, developed AIDS. Since 1990 and 2011, there was regular increase in HIV cases. This increase of HIV cases explained by efforts of MOH to improve HIV surveillance, testing, and reporting. A population-based survey was never conducted in Egypt. UNAIDS estimated number of people living with HIV in Egypt to be 11,000 till end of 2010. It is estimated 11,000. HIV transmission in Egypt in 2010, most transmission occurred sexually. About 2/3 of total cases, 46.2 are heterosexual. Most are heterosexual. About 1/5 are homosexual transmission. Transmission through IUD, about 28%. In addition, in 2010, 4.9 were children of various ages, denoting probable mother-to-child transmission. It is worth noting that out of total number of people who presented for voluntary counseling and testing services in 2010, about 20% of them were women. The changing epidemic of HIV/AIDS in Egypt. Despite low prevalence of HIV in general population, less than 0.02%, recent studies showed that Egypt had epidemic within certain specific risk groups as MSM and IDUs. Surveys in 2010 showed that HIV and MSM in Cairo at about 5% and in Alexandria about 7%. Also in surveyed males IDUs in Cairo at 7.7% and in Alexandria about 7%. Results reveal that Egypt is stepping toward HIV epidemic. Besides already known modes of transmission, blood-borne infections and mother-to-child routes were responsible for a sizable proportion of cases. An additional finding showed probable expansion in bridging population as the higher at-risk group practicing risk behaviors, FSWs, MSM, IDUs, have links with general population. Even MSM are either married and or have multiple opposite sex partners. Egypt is stepping toward a concentrated epidemic. Gender and HIV/AIDS in Egypt. According to national statistics in 2006, HIV seems to be prevalent among most productive population in Egypt, as about 90% of infected aged 15 to 49 years. Share of female in Egypt represent about 1/5 of people living with HIV infection. It is also important to note that when comparing male to female living with HIV, according to age distribution, coming slide, infection is concentrated in women at 20 to 34 years, men in same age group, more than men in same age group. Age shifting noted from detected cases indicated that population group most affected is adults at age group 25 to 40 years, and with increase in females affection as male to female ratio was 4:1. This is the age and gender distribution of reported HIV in Egypt 2007. This is modes of HIV transmission, Egypt Biological and Behavioral Survey. As you see, heterosexual 46%, homosexual about 20%, drugs injection about 28%, maternal to child about 5%. Epidemiology of HIV, agent factors. Reservoir are humans, cases and carriers. Once infected, virus remains in body lifelong. Symptoms takes years to manifest, so carrier can infect other people for years. Source of infection, virus found in greatest concentration from blood, semen, and CSF, lower concentration in tears, saliva, breast milk, urine, and cervical and vaginal secretions. Agent factors continued. Virology. HIV belongs to retroviruses. Two types. Type 1, HIV-1, type 2, HIV-2. Retrovirus are RNA, ribonucleic acid viruses. In order to replicate, they must make a DNA, desoxyribonucleic acid, copy of their RNA. It is the DNA genes that allow virus to replicate. HIV replicate only inside cells, making cells machinery to reproduce. Only HIV and other retroviruses, however, once inside the cell, use an enzyme called reverse transcriptase to convert their RNA into DNA, which can be incorporated into the host cell's genes. Host factors. Age. Most cases occur in sexually active persons aged 20 to 49 years. This group is the productive members of society and those responsible for childbearing and child rearing. Sex is still most common among homosexual and bisexual men. However, in more developed countries, disease is becoming more frequent among heterosexuals, especially young people. Continued host factors. High-risk groups, intravenous drug users, and people with many sexual partners are especially at risk from HIV. Higher rate of HIV infection found in CSWs and their clients, transfusion recipients of blood products, hemophiliacs. Certain persons are at high risk due to conditions of their occupation as truck drivers, military personnel, migratory labor, i.e. work-related disease. Survival in nature. HIV is a fragile virus. It cannot live very long outside body, so virus not transmitted by day-to-day activities as shaking hands, hugging, or a casual kiss. You cannot become infected from a toilet seat, drinking fountain, doorknob, dishes, drinking glasses, food, or pets. Also cannot get HIV from mosquitoes. Social factors in epidemiology of HIV. HIV is truly a social disease with medical background, rapid industrialization and increased commercial sex workers, migration of youngsters to urban areas in search for jobs and away from traditional social control of their families, staying away from family due to occupational conditions, poverty with consequent resorting to sex for money, trafficking of women and girl children, availability of pornographic media, especially on internet, are some of important social causes of this disease. Lack of knowledge about causation and prevention, and intense stigma associated with HIV further increase the problem. Transmission dynamics. Incubation period variable. Time from infection to development of antibodies is about 1 to 3 months, but from HIV infection to diagnosis of AIDS has range of less than 1 year to 10 years or more. However, it is about 75% of infected with HIV develop AIDS by end of 20 years. Period of communicability. Begin early after onset of HIV infection and extend throughout life. Infectiousness increase with increase of immune deficiency, clinical symptoms, and other sexually transmitted disease. Recent studies indicate it may be high during initial period of HIV infection. However, patients on ART are less likely to transmit HIV infection to others. Transmission of HIV transmitted from person to person by sexual contact. This is the first truth. Sexual intercourse is the leading way of transmission of HIV. Occurs mainly in high-risk groups as MSM, CSWs. During intercourse, virus enter body through mucosal linings of vagina, vulva, penis, or rectum, or rarely via mouth and possibly upper GIT after oral sex. Risk of sexual transmission is in direct relationship with amount of trauma and laceration of recipient's genital mucosa. So, receptive anal intercourse provides greatest risk. Rate of transmission from man to a woman is more than opposite. Likelihood of transmission increased by factors that may damage these linings, especially other sexually transmitted infections that cause ulcers or inflammation. Transmission of HIV continued. Sharing of HIV contaminated needles and syringe. Users of illicit parenteral drugs will have for a large number of infections. Needle sharing and dilution of drug with blood are common practices as engagement in high-risk sexual practices like exchanging sex for drugs and money. Transfusion of infected blood or its components, platelets, factor 8 and 9. Risk of concentrating HIV from transfusion of a unit of infected blood estimated to be over 95%. HIV transmission by blood is dose dependent. Transmission of HIV continued. Vertical transmission from infected mother to fetus. Vertical transmission is number one cause of HIV infection in children. Vertical transmission during perinatal period and during breastfeeding. VT risk related to maternal factors as viral load, disease stage, and CD4 cell count. Obstetric factors, infant prematurity, and extent of breastfeeding. VT has no threshold in viral load. VT risk increase in linear fashion with viral load. Mothers with viral load less than 1,000 RNA copies per milli not likely to transmit infection to their babies. VT in 15 to 30% of infants born to HIV mothers infected before, during, or shortly after birth. Treatment of pregnant women results in marked reduction in infant infections. Factors which increase risk of transmission of HIV. Common to all transmission categories: high viral load, lower CD4 cell count, presence of AIDS, seroconversion illness. Vertical transmission: older gestational age, vaginal delivery, choreo anomalies, first born of the twins, prolonged rupture, number of peripartum prophylaxis, no peripartum prophylaxis, lower birth weight. Breastfeeding: longer duration feeding, lower parity, younger age, mastitis. Sexual transmission: STIs, especially genital ulcers, male to male versus heterosexual, receptive versus insertive, anal, cervical ectopy, non-circumcised, rectal or vaginal trauma, menstruation, increased number of partners, IV drug use, sharing equipment, intravenous use, frequency of use, cocaine use, linked commercial sex, lower income. Occupational transmission: previous arterial or venous setting, deep injury, visible blood on device. Incubation period: it is from 2 to 4 weeks. Clinical picture: acute HIV infection, seroconversion illness. As viral load increased to be detectable in blood, patient becomes infective but has not yet begun to produce antibodies, which appear only after 2 to 12 weeks after infection. Period before antibody is a window period when person is infective but will test negative for HIV antibodies. Such patient diagnosed only by HIV RNA per P24 antigen testing in blood. Appearance of antibodies, seroconversion, produce one or more of fever, arthralgia, myalgia, lymphadenopathy, sore throat, mucosal ulcers, headache, and photophobia, meningitis, encephalitis, peripheral neuropathy, or myelopathy in 50 to 70% of patients. Illness lasts 6 to 9 weeks of infection, and as antibody titers increase in blood, viral RNA and P24 antigen. Asymptomatic carrier state: on average, virus replicates for about 10 years while patient is asymptomatic. Viral load increase and CD4 counts about 50 per UL per year. Symptomatic disease appearance only when CD4 count less than 200. AIDS-related complex to lesser AIDS. This precursor to AIDS with diarrhea for more than 1 month, fatigue, loss of weight, malaise, persistent generalized lymphadenopathy, more than 1 centimeter enlargement of lymph nodes at 2+ extra inguinal sites for more than 3 months in absence of other causes, or splenomegaly. Severe opportunistic infections are yet absent at this stage. AIDS, barring some rare non-progressors, most HIV infections progress to AIDS. Two kinds of manifestation of AIDS: those due to HIV itself, as AIDS dementia, complex weight loss, chronic diarrhea, and those due to immunosuppression, opportunistic infections, and cancer. Opportunistic infections, these are infections in immune deficient state, infections by obscure pathogens, typical presentations by known pathogens. Typical inflammatory response is absent, best diagnosed only by visualization and culture. Preventing opportunistic infections. Avoid exposure to pathogens by food hygiene, keeping away from your cat, protection during sex, e.g. condom, screening blood, and chemoprophylaxis. Primary prophylaxis effective in decreasing risk of pneumocystis, girovisi, toxoplasma gondii, and MAC infections. And this is primary prophylaxis. Antiretroviral therapy helps prevent opportunistic infections if it can keep CD4 count of at least 200. Prevention for tuberculosis in AIDS. Prophylaxis given to all HIV positive patients with tuberculin positive more than 5 mm. Due to immunosuppressive condition, we don't expect 10 mm, and 5 mm is taken for being positive reaction. Dosage isoniazid 300 mg daily for 9 months or 1 year. This is HIV infection stage based on age-specific CD4 T lymphocyte count or CD4 T lymphocyte percentage of total lymphocyte. The stage is based primarily on CD4 T lymphocyte count. CD4 plus T lymphocyte count takes precedence over CD4 plus T lymphocyte percentage, and percentage is considered only if count is missing. If a stage 3 defining opportunistic illness diagnosed, then stage is 3 regardless of CD4 plus T lymphocyte test results. Lab diagnosis of HIV infection. The first and last rows. HIV DNA PCR preferred test to diagnose HIV infection in infants and children. And the last one, HIV RNA PCR preferred test to identify HIV-1 infections. These three tests are not recommended. Treatment. There are several parts of treatment HIV: antiretroviral therapy, treating opportunistic infections, and chemoprophylaxis. Third is counseling the patient. HIV control. Controlling reservoir. Treatment cases with antiretroviral drugs, preventing HIV positive cases to donate blood, have sex, or entering drug user communities. Post-exposure prophylaxis for possible sexual or other non-occupational exposure is a crucial decision. Decision regarding need for ARV prophylaxis based on probability whether source is infected or contaminated with HIV, likelihood of transmission by particular exposure, interval between exposure and initiation of treatment. All this balanced against expected adverse effects associated with drug. Transmission of HIV due to puncture wound from needle in community is less than 0.3%. Estimated risk of HIV transmission episode of receptive benign anal sexual exposure is 5 per 1,000 exposure, whereas estimated risk per episode of receptive vaginal exposure is 1 per 1,000. So anal sex is 5 times more than vaginal sex. Post-exposure prophylaxis for possible sexual or other non-occupational exposure. all ARVs associated with adverse effects, about 25 to 36%, and the patient discontinue it due to its adverse effects. Use of daily nevirapine for post-exposure prophylaxis is not recommended. Such adverse effects not reported with single dose intrapartum per infant nevirapine used to prevent mother-to-child transmission of HIV. ARVs not used if risk of transmission is low. Benefits of post-exposure prophylaxis greatest when risk of infection is high, intervention is prompt, and adherence is likely. Breaking the chain of infection. Blood safety. Refrain from donating blood. All blood should be screened. Prevention of mother-to-child transmission. See later. Universal precautions. Strict sterilization. Injections kept to a minimum. Prefer IV fluids rather than blood transfusion. Protecting the host. Education. Awareness of HIV must be known widely. Stress upon use of condoms during sex, to stick to one sexual partner, refraining from sharing needles, razors, toothbrushes, using only sterilized instruments for piercing and tattooing. HIV positive women be taught not to get pregnant at all. Education campaigns should take advantage of all available media. Vaccine. There is no vaccine yet. However, several candidate vaccines are in line, of which GP 120 subunit vaccine is in trial. Post-exposure prophylaxis seems to be more important than pre-exposure. Prevention of parent-to-child transmission in HIV positive mothers. Proper counseling. Prevent early rupture of membrane during labor. Periodic cleaning of birth canal by iodine. Properly done cesarean section. Early cleansing of baby and bath. Use of breast milk substitutes. If possible, chemo prophylaxis. Immunization recommendation in HIV patients. This is important. All childhood immunization given to HIV-exposed infants. Children and adolescents with HIV infection immunized as soon as is age appropriate with all inactivated vaccines. Inactivated influenza vaccine given annually according to most current recommendation. The two-dose series of human papilloma virus vaccine, tetanus toxoid, reduced diphtheria toxoid, and cellular pertussis vaccine, and meningococcal conjugate vaccine all are indicated in HIV-infected adolescents. Continued immunization recommendation in HIV. MMR vaccine, a monovalent varicella vaccine, can be given to asymptomatic HIV-infected children and adolescents without severe immunosuppression. Severely immunocompromised HIV-infected infants, children, adolescents, and young adults should not receive measles virus containing vaccine because vaccine-related pneumonia reported. Quadrivalent measles, mumps, rubella, varicella vaccine should not be given to any HIV-infected infants regardless of degree of immunosuppression because of lack of safety data in this population. Continued immunization recommendation in HIV vaccine. Rotavirus should be given to HIV-exposed and HIV-infected infants, irrespective of CD4 plus T lymphocyte percentage or count. All HIV-infected children should receive dose of 23-valent polysaccharide pneumococcal vaccine after 24 months of age, with a minimal interval of 8 weeks since the last pneumococcal conjugate vaccine. HIV-infected children who are 5 years and older and have not received HIV vaccine should receive 1 dose of Haemophilus influenza vaccine. Infants and children with HIV infection 2 months of age or older should receive an age-appropriate series of meningococcal vaccine. وفي النهاية أقول الحمد لله الذي بنعمته تتم الصالحات و thank you for your good listening.